I'd like to move on to Dr. Ivan Hanson, Director of the Cardiac Cath Lab and Associate Program Director of the Interventional Cardiology Fellowship at Corewell Health, William Beaumont University Hospital, who will be speaking about PCI after TAVR, some things that Stan alluded to, and ideally give us some tips and tricks about how to do it best through the multiple valves that are now available.
Thanks, Devraj, and appreciate the opportunity to speak here today. So hopefully there'll be some overlap with Stan's talk, but I think that these two talks should go hand in hand, and there should be some overlap because the decisions that are made prior to TAVR impact what happens after the TAVR. And just by way of disclosure, relevant to this talk, as I am a proctor for Edwards and Medtronic. But we'll talk about here, when is PCI indicated after the TAVR? So just assume now the patient's already had a TAVR, and when would this come into play? And we'll talk more about some technical aspects. Stan did allude to some of these, but we'll go into a little more detail about how to do a coronary angiogram and how to do a PCI when there's a TAVR in place. So when would a PCI be needed after TAVR? Well, one commonly used delineation is quote unquote unplanned revascularization. So this would be most commonly acute coronary syndrome. Patients had a TAVR. We know that the prevalence of coronary disease is quite high in these patients with severe AS. Chances are you'll see a patient with this. And the mechanism is important, as we'll see in a couple of cases that I'll show. You have to answer the question of whether this is just a atherosclerotic plaque rupture, which is, basically run-of-the-mill coronary artery disease, or is it a mechanical complication of the TAVR itself? And then planned revascularization is as Dr. Chtcuti mentioned, it's really an unproven strategy, either before or after TAVR, to commit a patient to complete revascularization or any revascularization. It's being studied in complete TAVR and other studies that are in the design phase. So question, what percentage of patients require unplanned PCI within the first 6 years after TAVR? Is this going to be a
I don't know
audience
if it's on
response?
that. I don't know if it's on the
Okay.
Show hands. For A, 0.1%, B, 1%, C, 10%, D, 50% in the first 6 years after TAVR. All right, so it sounds like 10%.
Most of the hands went up with 10%, which is a reasonable guess. But there's actually some data, including this 15,000 patient analysis that looked at the incidence of this, and at least according to the study, it's closer to 1%. Now, at the time this study was done, you have to keep in mind it was a much earlier phase of the TAVR experience where we were treating a lot more, a lot sicker patients. If you recall Stan's slide showing kind of the evolution of TAVR studies since the beginning, where you had 90% of patients in the earliest high-risk inoperable trials. Almost every patient had significant CAD, to now we're treating lower risk patients, many of whom may not have any CAD. So you have to take that with a grain of salt, but 1% is still a significant number. If you have 100 TAVR patients that you're doing in your institution, or 200, you will see these patients. The first thing I like to think about is, if patient has a need for a coronary angiogram or a PCI post TAVR, know what you're up against. So we've got the different valve types, and you have to understand how these are constructed and how to get to the coronaries through or over these stent frames. So I don't have a mouse here. I can point to things, but on panel A, the left side of the screen, this is a superannular evolute prosthesis, and you can see that during the valve implant, we always try to line it up with these dots. And the dots basically are markers of where the commissures are on the valve frame. And with the latest thinking about the cusp overlap technique, we line up a fluoroscopic angle so that we isolate the non-coronary cusp, because right underneath the non-coronary cusp is the conduction system. And we want to be, as high as possible above that to avoid compressing that and causing the need for a permanent pacemaker post TAVR. But as was mentioned, that comes at a cost of being higher and therefore being potentially more obstructive to the coronaries. And if you look on the right side of the screen, you can see that some of the dimensions to be aware of are the fact that, there's a 13 or 14 millimeter skirt height on this particular type of valve. So if you have, a coronary that is in the bottom two rows of cells, your coronary ostium is right behind there. It's going to be very difficult to engage with a coronary catheter. And similarly, if your coronary artery is arising, right behind the commissure, which kind of goes up through the middle of the valve, you can see there on the right side, that again is going to be difficult to get a catheter past that and engage in a coronary. You may have to go to the side of it, or you may have to go above it. In contrast, if you look at the bottom side of the right side of the screen there, that's a balloon expandable intraannular design. So it's a very low stent frame. And you can see with the asterisks, the top layer, the top row of cells there are very large, and they're designed that way on purpose so that the coronaries are easily accessible through there. So in terms of a patient like patient number 2 of Stan's, knowing that the patient had coronary artery disease, may need to reaccess the coronaries at some point in the future, that's a decision that comes up pre-TAVR, is which type of valve to implant. And you may opt for a balloon expandable lower profile valve for that reason. This is just showing again how misalignment can affect coronary access. You look on the right side, you've got a commissure overlying the coronary. So you can imagine trying to manipulate a catheter in there to engage the coronary can be quite difficult. So this is a patient that had a Evolut self-expanding valve, and it was a right coronary artery culprit. There's a osteal stenosis, and to engage the right coronary, obviously the trick here is going to be navigating through those struts. Now the frame does jail the coronary ostia. It always will with an Evolut. And a rule of thumb here is usually you want to downsize the catheter by a half a size, both on the left and the right. That tends to work a little bit better. In this case, we were able to find a cell that we can engage the catheter through. Actually did an FFR, and it was positive. And also did intravascular ultrasound. Intravascular ultrasound, I use it in just about every PCI now, but especially with a complex situation like this, it should give you some very useful information. So it can delineate the ostium, not just showing you the stenosis severity and the plaque burden and the lesion characteristics, but it can show the relationship between the ostium of the vessel and the native aortic valve leaflet and the stent frame, all of which may come into play with an osteal lesion that needs to be treated. In this case, we were fortunate because the coronaries were very high. And so the native aortic valve leaflet is below this. So that really didn't come into play. So the only question was, how close is that stent frame to the ostium of the vessel? And by IVUS, we could tell there was at least a few, with an automated pullback, you can measure the length of things. We could tell there was at least a few millimeters beyond the ostium of the vessel into the aorta that we could extend a stent without interacting with the TAVR stent frame. So that's what was done. Very important to always use a guide extension, because what can happen here is if the stent gets caught on the stent frame of the valve, it can strip off the balloon. And so you always want to use a guide extension and basically intubate the vessel deeply with the guide extension, leading with the balloon. Even if you have to balloon track, like one of the cases we saw earlier, to kind of atraumatically get it in there. And then basically passively expose the stent by pulling the guide extension back. And once you have it where you want it, go ahead and deploy. Obviously, this is after lesion prep. In this particular case, we did use shockwave to prep the lesion. And then finally remove the catheter gently. Sometimes it's best to do that over a J wire, especially if you pull back gently and it seems like the catheter is stuck there. Don't just yank it, just put a J wire in and it should straighten it out and allow you to remove it. Case number 2 is a different patient now. This patient had ischemic ST changes and hypotension post TAVR, but this is the pre-TAVR CT. And not to belabor all these measurements, but there are some very important things to take away from a pre-TAVR CT when it comes to coronary interaction with the TAVR valve. So in this particular case, I just want to key you into the right side of the screen where you can see what we're measuring there are the leaflet length. We're also measuring the coronary height. And then one more measurement that's very important here that's not shown is the STJ height, the sinotubular junction height. So how high above the annulus is the sinotubular junction? And you can see the middle panel on the bottom shows you the sinotubular junction, the STJ. You can measure the diameter of that. Okay, so just keep in mind that what we're about to do is basically deploy a cylinder in there, and you'll see what can happen as a result of that. So the patient underwent a successful Evolute TAVR valve implant and initially did fine for the first few months, but then came back with ischemic ST changes and hypotension. And so the concern was, does she have an ischemic problem? And the first step that was done here when the patient was taken to the cath lab is an aortogram. And an aortogram is a good idea because it shows you the height of the TAVR valve, where in relation to the annulus it's implanted. Is it very high like this case, or is it lower? It also shows you the origin of the coronary arteries relative to the first few rows of cells at the bottom of the stent cage. Remember, there's a 13 or 14 millimeter skirt that goes all the way around the bottom. So you'll see how high the coronaries are relative to that. And then any other surprises. Like in this particular case, there's a high implantation depth. And then engagement of the catheters, there's different teaching on this in terms of which catheter to use. But I usually use a standard Judkins right and left curve, but again, downsizing by a half a size. But that may not work for every patient. So often, you have to make some changes, kind of, think on the fly, and then select a catheter that just works. In this case, it was difficult to engage either coronary, but this Amplatz curve seemed to be able to opacify both. The right coronary, as you can tell from this angiogram, looks grossly okay. You can see it's not even selectively engaged, and you've got good fill of the coronary and good reflux of contrast into the aorta. The left coronary, on the other hand, has an issue. So what is causing ischemia in this patient? Is it failure of the TAVR valve? Show of hands. Choice A, something wrong with the TAVR valve causing ischemia. Choice B, is it an atherosclerotic lesion in the left main that's doing it? Show of hands for B. Is it C, coronary artery obstruction? So that must mean everybody is going for D, coronary sinus sequestration. Okay, a lot of people didn't vote. Only about 5 people raised their hand in this whole room. All right, so let's just go back to what I showed you on the CT scan. So This is coronary sinus sequestration, and this patient was kind of the perfect setup for that. And I admit, we didn't really think about this going into the TAVR, but in retrospect, it all became clear. So what happens is, you can see in the panel A, you've got coronary leaflets. Those are the native aortic valve leaflets painted in green there. And then you have in panel B, an evolute self-expanding TAVR valves implanted. And what happens is that the native coronary leaflets get pushed outward, so TAVR is really a misnomer, right? It's not a replacement, it's an implant. So TAVI, I would argue, is actually the better term, because we're implanting a valve, but you can obstruct the coronary, or if the sinus of Valsalva is effaced, like this patient, you don't see much of a sinus of Valsalva, which is that outward, outpouching where the coronary arteries arise normally. You have a sinus of Valsalva, one on the left, one on the right, and then a non. Here, you don't have much of a sinus, so there's really no space in there. And so the leaflet can get tacked up and cause this obstruction. And if the sinotubular junction, which is that narrowing right above where the coronary arteries arise, where the aorta kind of comes in and forms that neck there, if that diameter is very small and very shallow, very low relative to the annulus, now you've created a scenario where you can just seal off the entire sinus with the native coronary leaflet. So in retrospect, that's what I was getting at with the pre-TAVR CT. So here we did have a left coronary cusp length that actually exceeded the length of the coronary artery and came close to the distance from the annulus to the STJ. That, coupled with a very small STJ relative to the size of the TAVR valve that we put in there, and this patient was a perfect setup for this problem. So, what was done here is, this patient had already been deemed inoperable for heart surgery pre-TAVR. And so we knew if we were to correct this, it had to be a percutaneous solution. So what was done here is, because we had a very high implant, the sewing skirt around the bottom of the valve frame really came into play here. And in addition to that, we suspect there may have been some misalignment with the commissure overlying the coronary artery. And so we couldn't get a catheter to engage the coronary. So the best we could do is to get it over top. And we had this XB curve with the catheter, which is the only one that really fit. With that configuration, we were able to get a guide wire and a microcatheter through a stent cell and into the sinus of Valsalva and kind of fished around in there, and we're able to wire into the coronary artery. And once we got into that position, we switched out the workhorse wire with a stiff wire that gave us more of a rail to advance equipment. Again, IVUS is key. I think the more complex the lesion, the more I rely on IVUS. So with this, we were able to show the lumen size of the native coronary artery, which is where, which I'll show you, came into play with what we're about to do here. But it also showed us what the problem was at the ostium of the left main. You can see the middle panel shows, almost an absent lumen. But it's not because of an atherosclerotic lesion. It's because of the native aortic valve leaflet that's been propped up and is obstructing, and it's sandwiched between the TAVR valve frame and the ostium of the left main. So to treat this, again, we use something called a snorkel stent technique, where basically a stent is implanted in the native coronary and extends back into not just covering the left main, but out into the aorta. That basically props open that distance between the TAVR stent frame and the coronary artery to allow blood flow. Sometimes we do this at the time of TAVR implantation. If we have a case where we suspect that this may happen, we can actually get set up to deploy a snorkel stent right after we deploy the valve. And sometimes we end up doing this at the same time, but in this case, that wasn't done. With that, the key here is you have to use a stent long enough to actually extend back beyond the STJ. Otherwise, it defeats the purpose. And you have to keep in mind that the stent will never be a perfect circle because you've got a huge TAVR valve, and you can't expect a coronary stent to have enough radial force to actually prop that away and be circular. So you have to accept the fact that it's going to be flat like this, but it really shouldn't matter because there's still blood flow getting through. So that's a snorkel stent technique. So, it was alluded to earlier, but TAV and TAV, when you have a patient that has a degenerated TAVR valve, what is going to happen in 10 years when, when they have, those leaflets degenerate. So this is something that is always in the back of our mind. Anyone that, does TAVR realizes this, the so-called lifetime management. But one of the main issues, the reason why this is important is coronary reaccess, because it's hard enough with one valve in there, let alone, you put a second valve in now, and just imagine, for example, on the right side of the screen, if you have a evolute prosthesis and now you implant another one and it's just slightly misaligned with the first valve, now you create, much smaller cells, and you may not be able to get a catheter in there at all. And so, these are some of the harder discussions to have. Doing a TAVR on someone is a relatively easy thing to do, but, understanding what the lifetime management of those patients is going to be, that's a much more difficult question. So in conclusion, unplanned PCI post-TAVR is sometimes necessary. I will bet that everyone in this room will probably encounter this scenario at some point. And then understanding the patient and the TAVR implant with a heavy reliance on non-invasive, particularly CT imaging and invasive imaging with not only angiography, but IVUS is crucial. Thank you.